So we are going to talk to you today about a program of research that we have been involved in for a number of years, looking at communication about miscarriage. Let's see if I can get this slide to advance. There we go. So our entire program of research is really undergirded by an assumption that is made clear in this quotation from one of our study participants. I can't think of anything else that's so common, but nobody talks about it. Miscarriage, or the loss of a pregnancy prior to 20 weeks, is an incredibly common experience. In fact, it's likely that all of us in this room know somebody who has coped with miscarriage, whether we realize it or not. As many as 25% of known pregnancies end in miscarriage. In terms of the broader effects of miscarriage, research that has looked at kind of the psychosocial effects of miscarriage has suggested that both women and men experience negative outcomes. For example, some women have reported levels of grief and depression after a miscarriage that are similar to the levels of grief and depression that one might experience after losing a close family member. These negative outcomes might be exacerbated when people have unsatisfying interactions with their healthcare providers. And so our work in this broader area of miscarriage really has two strands. So I'm going to talk about the first strand of research today, and then I'm going to turn things over to Dr. Brand, and she's going to talk to us about our second line of research. So one area of research that we have looked at is the relational implications of pregnancy loss. More specifically, we have looked at couple communication after a miscarriage. Then we've also, more recently, been looking at communication in the clinical context. So how do healthcare providers talk to patients who are coping with miscarriage? We've looked at how healthcare providers can help or hinder the decision-making process as women decide as patients how they want to manage the physical aspects of miscarriage. And we've also looked at how healthcare providers deliver bad news, particularly when a loss is unexpected. So I'm going to talk first about the couple communication work that we've done. So I'm going to talk about this study that Erwin mentioned in the introduction that was published in 2015 in the Journal of Applied Communication Research that looks at what is called co-ownership of private information. And I'll talk more about what that means and what that looks like for couples. So although miscarriage is incredibly common, it's a pretty stigmatized topic. So plenty of research suggests that people feel pretty uncomfortable talking about this topic, that people have reported very awkward kinds of conversations when they disclose to somebody that they've been through this experience. Some people have noted that it just makes everybody in the interaction feel uncomfortable. And so some scholars have suggested that it makes it even harder to cope with a traumatic situation when you feel like you can't talk about it. So that was one of the assumptions that we wanted to explore as we looked at couples' communication about miscarriage. We also then recognize that miscarriage is often a communal experience. So particularly in situations where you have couples who are in a committed relationship and experience the miscarriage of a desired pregnancy, we suggested, for purposes of this study, that that's an experience that affects both members of the couple. Most of the research that looks really in depth at kind of the social and psychological effects of miscarriage has tended to look more at women's experiences than men's. And we were really interested in the relational experience of the couple as a unit. So for this study, we drew on a popular and well-known theory in our field of communication studies called communication privacy management, or CPM. And this is a theory that suggests that as individuals, we feel that we have the right to control personal information about ourselves. So for instance, if you are diagnosed with a chronic health condition, this theory would suggest that you have the right to tell or not tell other individuals about that health condition, and that you feel like you have ownership to manage how that information is handled. The theory also says that sometimes private information can be co-owned, meaning that multiple individuals might feel like they have the right to control a particular piece of information. And we suspected that this might be the case with miscarriage, that perhaps both members of the couple would feel like they had the right to make decisions about who to tell, how to tell, and so on about the miscarriage experience. Most of the research on privacy management really focuses on the individual level experience. And the few studies that have looked at the possibility of co-ownership have not really given us a lot of detail about what that might look like. One study in particular looked at couples' experiences of infertility, which is closely linked to the experience of miscarriage. In this particular study, the researchers found that men and women in couples described disclosing at what they called discrepant levels. More specifically, what they found is that women disclosed more often than men did. In this study, they interpreted that discrepancy as a potential problem. We wondered if that was really the case, if sometimes couples might disclose at discrepant levels, but maybe that's okay. Maybe they've worked that out. Maybe there's an understanding in the couple that one person is going to talk about it more. And so that's also a contribution that we wanted to make with this particular study. So we posed 3 specific research questions in this part of our investigation. We wanted to know if couples did view information about a miscarriage as co-owned, so to what extent did they co-own private information? We wanted to know what rules couples developed for how to handle that information, and we wanted to know how couples developed rules for how to manage that information. So this study was a qualitative project where we used an interview method to talk to 20 married couples who had experienced a miscarriage. All of the couples in our sample had experienced a miscarriage prior to 20 weeks, sometime in the 3 years prior to the interview. And we recruited our sample in a variety of ways. We recruited through social media. We recruited through support groups in the Indianapolis area that focus on infant and pregnancy loss. Our resulting sample was rather homogeneous in its composition. So you can see the average age for wives and husbands was around 34 years. They had been married an average of 7 years, but we had a pretty wide range, some in newer marriages of about 3 years to as many as 19 years. Our sample happened to be highly educated and Caucasian. So we can think about the strengths and limitations of having a sample that's pretty homogeneous in nature. And it happened that although we did not recruit specifically for this, we had a sample of heterosexual married couples. One of the aspects of our sample that was pretty unusual and that I'll talk more about later is that we had a rather large number of couples in our sample who had actually experienced multiple miscarriages. So out of the 20 couples, 12 of them had experienced multiple losses. One couple had experienced 6. This is somewhat unusual. Multiple miscarriages are not statistically common, but for whatever reason, in our sample, we ended up with more than half of our sample who had gone through that experience. So we conducted joint interviews. Because we were framing miscarriage as something that is a communal experience in committed couples who lost a pregnancy that they had really hoped for, we interviewed both members of the couple together at the same time. And so we could see not only how couples talk to us, but how they talk to each other during the interview. The interviews lasted around an hour and a half each, and we used some of the concepts from communication privacy management theory to help us understand the kinds of things that couples were telling us. So we did find that couples very much viewed the miscarriage as something that was co-owned. And we could tell this in a couple of different ways. When couples would tell us their narrative during the interview, they would narrate the stories together. Sometimes they would take turns describing what had happened. And they often used the pronoun we. We both lost something. We went through it together. We also found evidence of co-ownership in interview excerpts where participants talked about kind of checking in with each other when they were disclosing the information to people outside the couple dyad. So part of the process of dealing with communication after a miscarriage is telling family and friends and sometimes coworkers and people in your social network, or sometimes not telling them. And so couples would talk about how they would communicate with each other about who else they were telling. We're both a couple, and it was both of ours baby, but since it's such a personal experience for the two of us, I wanted to make sure that was all right to talk about that. So kind of checking in with your spouse before telling other people. I've asked him before I told something, like, is this okay? So many couples describe this process of checking in with each other. Even though there was evidence that both couples had an understanding that they had the right to talk about this information with their social network, we did find that women were often framed as sort of the primary owners of this information. So both men and women in the sample would talk about how even though this was a traumatic loss that affected us as a couple, it's the woman who goes through the physical experience of this loss. And so we talked about that in terms of the embodied experience of miscarriage. So one of our husbands said, I was letting you, meaning his wife, take the lead on it for the talking about it. I never felt like it was my place to do that. It happened to us as a couple, but more on your end. So very much acknowledging the physical process, which is sometimes a painful physical process of the loss. This is a quotation from one of the wives in our sample who had heard her husband talk about the fact that he sort of deferred to her when it came to deciding who else they were going to tell about what had happened. And she said, if it got shared at all, it was me who did the sharing. And we didn't talk about why that was, but hearing Kent talk about it, that makes perfect sense that this was my information to tell. It hadn't happened to him, meaning that the physical process had not happened to him. Our second research question asked what kind of rules might couples establish about who gets to know this really personal, sensitive information about something that happened to us. So couples frequently talked about telling other people who had had a miscarriage. One of the interesting aspects of our analysis is that couples often talked about how after they had a miscarriage and they disclosed it, they found out that all these other people in their social network had gone through the same experience, but they didn't know it. So some people had family members who had had a miscarriage and they had no idea until they had gone through their own miscarriage and had shared that with family members. So this is somebody talking about getting some support from somebody outside the couple who had also gone through this experience. Him and his wife had experienced a miscarriage at 7 months, so he talked to me about it, and it was very honest because he said to me there was support there, but he said it's gonna suck. There's no way around it. One of the other tricky things about talking about a taboo topic like miscarriage is just how to bring that up in a conversation. So sometimes couples in our sample would talk about, well, I only disclose if somebody else brings up this topic. I don't usually bring it up unless somebody brings it up to me, or if I hear, like if somebody says, you know, so-and-so lost a child, then I will start. So it can be difficult to find the right conversational moment to broach this kind of topic. Sometimes couples felt like they had an obligation to tell. So one complicated aspect of talking about miscarriage is that sometimes a miscarriage occurs after you have told everybody that you're pregnant. And then couples felt like they had to sort of go back and untell that joyous news to let people know. One person in our sample talked about a situation where a coworker came in and asked her how she was feeling, how her pregnancy was coming along, and the coworker did not know that a couple of weeks prior she had had a miscarriage. So there's this tricky kind of intermingling of announcing something that's really exciting and then dealing with those announcements if a loss occurs. This person said we had already told everyone under the sun about our pregnancy, and so when we lost the baby, we had to tell everyone. Couples were also particularly sensitive to finding people who they felt could be supportive for them. I would reach out to my friends to talk to them about it because it was something that I was really sad about and needed to work through. In addition to talking about sort of the types of individuals to whom people would disclose about their miscarriage experience, the issue of timing was a particularly salient and sometimes difficult issue. And we'll talk more about this as I present some of our other findings in this area as well. But one of the issues about timing has to do with when you tell that you're pregnant. So we have this sort of what's considered the safe zone in pregnancy. Most miscarriages happen in the first trimester. And so couples in our sample reflected on making decisions about whether they were going to wait until they were past that first trimester to tell, or if they had told early, how they might handle that. This quotation is from a couple who reflected on this idea of timing. We've come to realize that a lot can happen in the first couple of weeks of a pregnancy. So at what point do you feel comfortable telling others, knowing that you might have to retract it a month later? I think that sort of played into when we plan to announce any sort of pregnancy at this point. So this was a couple who'd gone through a miscarriage, but wanted to try to get pregnant again, and they were already thinking about, well, we know now that this could happen because we lived through it, so how might this affect how we will tell people in the future? We also then looked at how couples formed privacy rules. And so we found that couples would sit down with each other and have these explicit discussions about who we should tell or when we should tell. But what was interesting about that is when we asked them in the interview, did you two have sort of conversations about how you wanted to handle this information? Many times they would say no. And then later in the interview, they would describe a conversation where they had done just that. So we speculated that there might be established relational patterns in a couple that maybe didn't make those conversations quite so obvious. So when they were asked about them, they might have said, no, we didn't really talk about that. But then they would certainly describe conversations where they had indeed talked about rules for handling that information. Sometimes rules were established when partners would process with each other after a conversation had occurred. So one spouse might come home from work and say, you know, I told my manager today about what happened with the pregnancy loss, and here's what happened. And maybe if it was a negative experience, they would decide, you know, let's not talk about that at work anymore. So sometimes couples would process what had occurred in a conversation and then develop rules based on that. So we can very much see in terms of implications that even though women were framed as the primary owners of information, that both men and women talked about a need to disclose the information to at least some people in their social network and to seek support. So both husbands and wives have something at stake when it comes to how we handle this information from a relational perspective. Sometimes the miscarriage experience can prompt people to form new privacy rules about who they talk to, what they talk to them about, and they might adjust that as they move through this kind of intertwined experience of moments of joy and also moments of great loss. We also suggest that there are practical implications to these findings. So there's been some work in sort of the therapeutic realm that has looked at turning points that people might progress through as they're dealing with the loss of a pregnancy. And that work has recognized that going public or disclosing that you've been through this experience is an important turning point in that process. Much of that literature is written from a very individualistic perspective, mostly geared toward women. What we would suggest is there are plenty of situations where we need to keep in mind that this is a communal experience. So going public might just not be just an individual decision, but might be a co-owned decision. We also found that meta-communication, or talking about your talk, is important to this process. So couples in our sample disclosed that they processed conversations with one another and developed privacy rules based on those conversations. And finally, we know from our work and from other literature as well that other people who have experienced miscarriage can be a really important source of support. There aren't very many formal sort of support interventions that have been developed and tested to help people cope with miscarriage, and our work certainly points to a need to continue to develop those interventions. We looked at this same sample of interviews from a slightly different perspective that also has to do with privacy management, but instead of just looking at what couples were doing to manage private information, we were interested in the idea that we have sort of societal level expectations for how people should talk about specific topics. And we used miscarriage as an example of that. So this work is from a paper that is currently in press at the Journal of Social and Personal Relationships. And so it's based on the same set of interviews. We were interested not so much in the communal aspect in this analysis, but we were interested in this paradox that I mentioned earlier, that miscarriage is really common, that almost everybody knows somebody who's gone through this. But despite being so common, it's something that we still feel pretty uncomfortable talking about in everyday conversations. A recent survey study that was published in 2015 suggested that the average person vastly underestimates how common miscarriage is. In this particular study, they found that most people thought that around 6% of pregnancies end in miscarriage. That number is actually much higher. People also reported really misunderstanding what causes miscarriage. So, for example, in this study, respondents thought that being under stress or lifting heavy objects were common causes of miscarriage. And that's actually not true. In most cases, we don't know exactly what causes miscarriage. The speculation is that it's some sort of genetic abnormality. And so the idea that we might imply that women are at fault for miscarriage and that we don't really understand how common it is can contribute to why it's so difficult for people to talk about. We used the same theoretical framework that we used in our previous analysis, but we drew on different assumptions from this theory. So we looked at the idea that CPM, Communication Privacy Management Theory, suggests that we have culturally specific understandings about privacy. And in particular, we have expectations for how to handle specific topics. For example, previous work in this area has suggested that we have sort of cultural expectations for how we talk about money or don't talk about money. We speculated that these same kind of understandings also shape how people talk or don't talk about a really taboo topic like miscarriage. The theory also says that these privacy rules that we talked about in the previous analysis are sometimes something that we negotiate with a partner, like a spouse, but sometimes they're just sort of these rules that we learn, that they're acquired through socialization. And so we used these assumptions to try to understand how this might play out in the miscarriage context. So we suggested that we have societal level privacy rules that are collective rules, meaning that they're shared by a group of people, that they're pre-existing rules that we learn through socialization, and that they're routinized. They become patterned ways of thinking about or talking about communication surrounding a specific topic. And so we use this concept to ask some questions about how this might play out in the miscarriage process. So we wanted to look at, do these broader kind of societal expectations shape our interpersonal communication? Do they shape how we talk or avoid certain topics in our everyday conversations? So we posed 3 specific research questions and went back to that same set of interview transcripts to look at them from a slightly different angle. And so we wondered, did couples talk about societal level privacy rules that they perceived? And if so, how did this shape their privacy management? And what, if any, privacy rules do couples recalibrate when coping with miscarriage? So part of what can happen when we're dealing with an issue over the long term is sometimes we adjust our privacy rules. And so the concept of recalibration talks about how we might adjust our rules, reformulate them, or even develop new rules over the long term as we process and deal with a specific issue. So our findings, again, are drawn from that same sample of 20 couples in those joint interviews. And so the first thing we did was we went back to that data to see, do couples talk about this perception that there are these bigger privacy rules about how they should handle miscarriage? And indeed, that's what we found. Couples in our sample would often talk about, well, society seems to think this, or because of this societal pressure, we might do X, Y, or Z. And so they used the word society in their own language to describe what they perceived to be going on. So by far the most common perception was that you aren't supposed to talk about this. It's just one of those things you're supposed to keep behind closed doors. And here are a couple of quotations that illustrate this idea. It's just more of a silent thing that's just not talked about socially, and usually when somebody does say something, they usually say the wrong thing. I didn't talk about it because nobody else talked about it. So even though there were situations where couples did disclose their miscarriage, we saw that in the previous analysis, by and large they felt like it wasn't something that they were supposed to keep talking about. This perception was especially amplified for men in our sample. So the second societal level rule was that guys are not supposed to talk about this. So not only is it a taboo topic, but it's especially taboo along gendered lines. It seems like it's viewed as a female job of grieving the miscarriage, which is kind of challenging. That's a quotation from one of the husbands in our sample. She's the one who's going through the emotional and physical trauma, so be strong for her, be there for her, be supportive of her, and it totally negates or invalidates the emotional trauma that the husband goes through this experience as well. So husbands had these sort of contradictory emotions where they felt like they wanted to be supportive of the traumatic experience that their wives might be going through, but then at the same time felt like their experiences were often neglected. The final rule has to do with something we mentioned earlier, and it's the idea that we have this societal rule that you're not supposed to tell people you're pregnant too soon. So there's this assumption that you should wait until you get through that first trimester before you tell people that you're pregnant. It just seems to me like there's such a pervasive attitude in our society that you shouldn't even announce a pregnancy in the first trimester because something might happen. That something, of course, is referring to a miscarriage. The timing issue was really tricky for couples in our sample. So we had some couples who had announced the pregnancy, and then as we saw in one of the earlier quotations, had to go back and tell everybody else about the miscarriage. We had other couples who had waited. They were going to wait until they made it through the first trimester and miscarried before they had really shared the news with people, and then they had to decide how to handle that situation. Do they just keep it a secret, or are they faced with this sort of double disclosure of telling people that they were pregnant but they aren't anymore? So in terms of shaping privacy rules, we found that the rule about timing, as well as the rules about gender and keeping it behind closed doors, really affected how people talked about this issue in their everyday conversations. Sometimes people in our sample talked about outwardly defying this rule. And in fact, this was something that only women in our sample talked about. So some women would say, I know I'm not supposed to talk about this, and so I talk about it more. It was almost like it was this small act of rebellion. I think it is, yeah, a taboo topic. I think it's probably something that maybe motivates me to need to talk about it more, because I think people shouldn't be ashamed to talk about this, or people who have experienced it shouldn't feel bad. They should have some kind of platform. So if me bringing it up gives someone else the courage to bring it up, or just gives them an avenue to say, oh my gosh, I dealt with that too, then that's great. Unfortunately, men did not feel like they had the same luxury. They didn't feel like they had the freedom to defy those rules in quite the same way that women did. So men in our sample, by and large, talked about feeling constrained by the gendered expectation that this was not only an off-limits topic, but was especially a topic that was not the domain of men. It was very much viewed as the domain of women. Like, everybody knows the woman is going through the pain, but nobody knows what the men go through at times. Finally, then, we can return again to the influence of that 12-week rule. So this is an example of a quotation from a wife and a couple, and this couple had chosen not to announce their pregnancy. They were planning to wait until they got through that first trimester, and then that didn't happen. So for those 10 weeks, this was a woman who had miscarried at 10 weeks, I was keeping it a secret because I wanted to wait to tell them at least 12 weeks. And so then when I miscarried, it was like they didn't know that whole part of me that had been going on for the last 10 weeks. And then again, couples are faced with, well, now how do we handle this news that not only were we pregnant, but we have also experienced a miscarriage? Our third research question looked at this idea of recalibration, whether couples needed to readjust some of their privacy rules in response to these societal level expectations. And we found that this was especially amplified when thinking about the societal level norm that you don't disclose until the end of the first trimester, and was particularly apparent for couples in our sample who had experienced multiple losses. You might remember that we had over half of our sample included couples that had experienced more than one miscarriage. We tried to keep the third miscarriage on we didn't talk to too many people about it for the specific reason of not wanting to have somebody say, well, what do you keep trying for? So one of the difficult issues they faced was the timing of the pregnancy announcement, and also the fear of judgment, that people would not understand, why would you try to keep having a biological child if you've already been through this, especially if you've been through this multiple times. Sometimes couples dealt with this by telling early and telling more people. So we had a few couples in our sample who had gone through multiple losses, and they described telling more people with each pregnancy, like they were sort of trying to activate that support network so they would be there for them if another loss occurred. I think we told more and more people as we went. So we told the fewest number of people the first time, slightly more the second time, and we told not everyone, but a larger group of people the third time. So what we can see from this analysis is that couples in our sample readily articulated these pre-existing collective routinized rules that guided the way they themselves thought about communication about miscarriage. And it might shed some light on why something that is so common is still considered a taboo topic. It's because we have these sort of ingrained expectations for how we should or should not talk about this particular issue. And in terms of practical implications, going back to some of the work that I talked about earlier, we want to recognize that not only is this a co-owned experience, but there might be societal pressures that constrain the way that people talk about miscarriage in their everyday conversations. So any sort of intervention needs to take that into account, and particularly developing support materials that are specific to men might help men feel like they have some coping resources available to them. So I'm happy to answer questions about this aspect of our research at the end of the talk, but I'm going to turn things over to Dr. Brand, who's going to talk about our work looking at miscarriage communication in the clinical context.
Thank you, Jen. Sorry. Yeah, so we're going to go ahead and switch gears a little bit. So Jen has had the opportunity, Dr. Butts talked about the relational aspect, and some of our more recent research has really looked at communication with the patient and provider in a clinical context. And so we really explored two primary areas in this, looking at how providers can give information so that patients can make informed decisions when they're dealing with a miscarriage, and then also how providers can provide this news, this bad news, more empathetically. So I'm going to start with our informed decision making. And actually, I should say this work is in the Patient Education and Counseling Journal. It's in press right now, but it is available online through their June 2017 issue. So in a 2010 issue of Patient Education and Counseling, there was a group of physicians who published an article that argued that early pregnancy loss is an ideal context for informed decision making. Okay, because early pregnancy loss involves multiple decisions that have to be made, and there are many viable options for managing a miscarriage. We have to figure out what's going to be the best option for each woman. They go on to say that the first trimester of miscarriage is a preference-sensitive clinical scenario. So what might be right for one woman is not necessarily right for another woman. And so we have to figure out what is the preference for that woman. So I mentioned that there are actually 4 viable management options for managing a miscarriage in an uncomplicated early pregnancy loss. So the first thing that a woman could do is what's known as expectant management, and that basically is a wait-and-see process. So basically, you just wait for the body to naturally take care of the pregnancy itself. Medical management is similar in that, but there's medicine that's involved to speed along the process. But still, the woman would, dispel the pregnancy on her own. It could happen anywhere in her own home. She wouldn't have to be in a hospital for this to happen. And then the last 2 options are surgical options. So the first one would be an in-office aspiration where a woman's put under local anesthesia, or she could be put in, under general anesthesia in a surgery room to have this done, often referred to as a DNC. Some people have heard of that, the dilation and curettage. So what we know is that women have a strong preference in how they want to manage their miscarriage. So what I mentioned before, what's right for one woman may not be necessarily the best option for another woman. And our clinical practices don't always align with those preferences. And we know from previous research that women often make decisions based on fears that they have or some kind of emotional concern or consideration. But the problem is providers aren't asking necessarily about what these concerns are, and women are not voluntarily giving this information to the providers. So, for example, if women fear seeing, they call this products of conception. That's when a woman loses the pregnancy, it's called products of conception. So if a woman fears seeing that at home, then a surgical option might be a better option for her, so that way she is not going to have to face that. However, there's many women who fear anesthesia and what that could do. So if they're afraid of anesthesia, then a surgical option may not be the best approach for them either. Instead, they might want to manage this either medically at home, or an expectant management approach. So we were really interested in the type of communication that providers were giving to patients to help them make an informed decision on what was best for them. And so we pull on the work of Braddock and his colleagues, who's done a lot of work in informed decision-making in a variety of clinical contexts. And this has been applied to other contexts by other researchers in periviability and psychiatric care. And we wanted to see if we could apply this then to the miscarriage context, since we've already been told that this is an ideal situation and where informed decision-making should make sense. So Braddock and his colleagues say that there are 9 elements that a provider should engage in order to help someone make an informed decision. So the first thing is being able to discuss the nature of the decision that needs to be made, which is basically you need to know what your diagnosis is and what that diagnosis means. The second is a description of the alternatives. For this scenario, it would be the management options. So being informed of all 4 of those management options so that way you can decide what's best for you. And the third, related to that, is talking about what are the advantages and what are the risks associated with all of those different alternatives. So you need to know that in order to make an informed decision. The fourth is discussing the uncertainty of the situation, of the diagnosis, of the treatment options, because if anyone's been involved in any kind of medical situation, there's oftentimes a lot of uncertainty. We don't know exactly what's going to happen or what we should expect, and so we'll be discussing that. The fifth element is assessing the patient's understanding. If you're asking someone to make an informed decision, you want to make sure they understand the information that you've given to them. So being able to assess, does a patient understand what you've just communicated with them? Discussing the patient's role in the decision-making process. So the patients have a role in making a decision because there's 4 options that they can choose, and they're all viable options. So a provider typically will not tell the patient what they need to do. The patient has to be active in deciding what's best. Exploring the context, this is looking at how this diagnosis and then ultimate treatment options would influence daily living. So figuring out which management option is going to fit in best with her life. Assessment of the patient's desire for others' input. Since we're asking people to make an informed decision, a lot of times we want to get input from other people, whether that be talking with friends or family members or just other providers even. And then exploring patients' preferences. So as we already said, women have strong preferences for the way they want to handle the situation. So for this study, we were particularly interested in evaluating an obstetrics and gynecology resident's ability to engage a female standardized patient in the informed decision-making during this scenario. And I'm going to explain what specifically we did to make sense of this. So we engaged in observations of interns, which are first-year residents, who were participating in what's known as an OSCE, which is an objective structured clinical examination. So residents will perform these OSCEs at the end of each year of their residency. And what they do is they will go into a simulation center, and they'll have somewhere from maybe 10 to 12 different stations where they go into an exam room and they're going to be assessed on some skill. So a lot of times it's a technical skill like suturing or something like that, but we were interested in the communication skills. Right? So we actually, over the last 5 years, have observed these interactions with the residents engaging with a standardized patient who is a trained actor. So the standardized patient is given a sheet that describes, how she's supposed to behave in a certain situation, what her symptoms are, these types of things, and then the resident will come in and pretend that this is actually a real real patient, and then they're assessed on their skills by attending physicians to afterwards discuss how well they did in that station. So the trained actor in this case is Mrs. Jones, who comes in 9 weeks pregnant. She's asymptomatic. She's not having any kind of symptoms. She's just there for a routine ultrasound. And she's waiting for the physician to come in and discuss the results with her. And the resident's note tells them that this woman has come in for a routine ultrasound and there is no heartbeat. So the ultrasound shows there's no heartbeat. So the woman doesn't know, and you have to go in there and tell the woman that she's having a miscarriage and explain the management options to her. And I think it's important that we note that interns, these first-year residents, have not received any kind of formal training in how to do this. So it's just through maybe what they've observed their attendings doing that they are learning how to do this. Okay. So we were sitting in a control room watching these live, and then we also have the video recordings that we could take back and observe and code as well. And we decided to use Braddock's coding scheme. This has been validated, as I mentioned before, in other scenarios. Looking at those 9 elements of informed decision-making. And then we also assessed 2 other elements. We assessed the exploration of patients' concerns, because we know specifically with the miscarriage context that often determines whether or not, or how a patient is going to make their decision on what they're going to choose to manage their miscarriage. And then also, for those of you in the communication field, you know, the work of Rick Street really talks about supportive statements and how support really will influence our decisions and how we make those decisions. So we wanted to assess those as well. So as an example, this is actually the first page of our coding scheme, just so you can kind of see what we were doing here. And these are just the first two elements of Braddock's coding scheme, where the first one there, that nature of the decision, we assess this both quantitatively and qualitatively. Quantitatively, we want to know, did the resident provide the patient with a diagnosis and explain what that means? And then qualitatively, we want to know what kind of language were they using to describe this. So with Braddock's scenario, with his coding scheme, what he argues is that we can do this partially, or we can do this completely, or we can do this not at all. So this is how we're assessing it. So if the diagnosis was never given, that's coded as absent. If the diagnosis was given but maybe not explained what that meant, that would be considered partially communicated. And then complete would be saying something like, you're having a miscarriage, which means your baby has died, or there is no longer a heartbeat. So the examples here are actual language that was used by the residents in these scenarios. The second one here is the alternatives. So again, if they didn't go through any medical options, that would be absent. If they went through some but not all, that would be coded as partial. And then if they went through all of the medical options, all 4 medical options, that would be considered complete. And I wanted to put this up here to let you see that all of the residents are assessed by another physician. And this is actually the evaluation form that the physicians are using. And so what's interesting to us is when we started to map out the informed decision-making elements, they map on here, many of them map on here very nicely to what they're already being assessed on. So even though they haven't had this type of formal training, they're expected to know how to do this. And physicians are looking for this when they're assessing the residents. So what did we find? Well, first of all, the residents are doing okay. And I say that because they do what Braddock terms as minimal informed decision-making. So they argue that in order to be minimally engaged, there are 2 things that have to happen. One is you have to communicate the nature of the decision. You have to disclose that diagnosis. And then you have to do one of 2 things. Either discuss the patient's role, so they're aware of what kind of role they have in making decisions, or you have to explore what are their preferences, what do they want to do. Okay, so the residents are doing that. They're meeting the minimum. But what you'll see is there's a lot of room for improvement. Okay, so most elements, nearly all the elements, were only partially addressed if they were addressed. So I'm not going to go through all of them, but I do want to highlight a few things. So as you saw on the other screen, all of the residents communicated what a miscarriage was, that the woman is having a miscarriage, and communicated what that meant. Now, some did that more clearly than others, because you'll see, or you would see in some of these that there's some confusion sometimes. And so they'd have to go back and clarify, but they did communicate this information. In terms of the alternatives, all right, we're asking women to make an informed decision, yet only about 1/5 of the residents gave them all the options to make that decision with. So about 3/4 of them would mention some of the options, but not all of the options. So it's very difficult for a patient to really make an informed decision if they don't know what all their options are. In terms of talking about the advantages and the risks that could go along with these decisions, only 16% provided those pros and cons for each of the option that they presented. Okay, so we weren't even looking at all the options because most people weren't doing that. But of the options they presented, only 16% talked about both the advantages and disadvantages of that option. What we did find, though, is they would do it partially. So they would most of them would either provide just the pros or just the cons to those options, or they would talk about pros and cons to maybe 1 or 2 options, but not all of them that they presented. So again, that's troubling when trying to make an informed decision if you don't know what the advantages and what the risks are for each option. Okay. Now, in order to make an informed decision, we need to make sure that the patient understands that information. And no one did this completely, and only 12% were assessing understanding. We coded as partial, and they were typically doing it by asking things like, did you understand? Which we know is not an effective way to assess understanding. So instead, they should be asking things like tell back techniques. Like, tell me what I just told you, to see if they can even tell back. And that's a very limited way to assess understanding as well, but it's better than just, do you understand what I'm telling you? And then assessing here whether or not they explored these emotional considerations that they have. Well, none of them did that on their own, and none of them did this completely. Again, only 12% did this partially, and they usually spoke about generalities, or they spoke about fears in generalities. So like, some women have expressed concern about, but not specific to the patient. And when they did talk about it, it was always initiated by the patient. So the patient might have said something, and then they would say, well, some women have experienced this. So never really fully exploring that. And then the last one that we want to bring up is because this is really key for helping women to decide what's the best option for them personally, is exploring the context. So how does this affect their daily living? And no one was doing this completely, and only 19% were partially doing that. And they did this in a way, instead of asking women things like, do you work outside the home? Are there other children? These types of things to figure out how these treatment options might affect their daily living, they would just say something like, well, you need to think about your daily activities to figure out what's best. So what does this mean? Well, from our perspective as communication scholars and from this validated coding scheme, the residents are doing something right? They're doing that minimum informed decision making. But like we said, we know that there's room for improvement. And so what we're arguing is that there can be effective communication skills training given to these residents to help them inform, engage, and empower patients. And particularly what would be most useful for them from this study is really encourage them to explore the context by asking explicit questions of the patient and engaging them, by assessing their understanding through recall techniques, so that way we know that they are making an informed decision, and then exploring patient concerns. So asking what concerns they might have, ask what fears they might have, but then also really responding to the verbal and nonverbal cues that patients have. So when the patient is obviously very visibly distraught, and the resident doesn't take an opportunity to explore why or what is causing that, if there's something specific besides just getting this information, then that can be problematic and it would be difficult to make an informed decision. And then what I want to talk about is how we've started to use some of this information as we move forward and doing a little more analysis from a little bit different perspective. So we're using the same data set. We've actually brought in a graduate student to help us with this, and this we actually just got under review. But we're looking at best practices for providers when they actually deliver the bad news of the miscarriage diagnosis. So just to give you a little bit of background, we know in many contexts that healthcare providers feel very unprepared to communicate about traumatic events. And a miscarriage can be particularly traumatic for women who have a desired pregnancy. So when they lose this child, it's going to be very traumatic for them. And women report being very unsatisfied with the communication that they receive from their providers during that interaction. We know from research that when healthcare providers communicate in an empathic way, it has a tremendous effect on women's mental health. So yes, we have to deal with the physical health aspects of losing this child, but we also have to think about the mental health that's happening as well. And so communication can go a long way in improving some of the mental health issues. So specifically with this study, what we were seeking to do is determine women's preferred communicative strategies and desired content that health providers could then use when they were in a miscarriage situation. So what we did is, with those 40 patient encounters that we have the videotapes of, is we chose 6 different clips to share with women who've experienced a miscarriage. So we had done some analysis of the videos based on previous research that suggests there are some effective and ineffective ways to communicate. And so we used an effective and ineffective clip of delivering the diagnosis, an effective and ineffective clip of explaining what those management options are, and then also an effective and ineffective clip of discussing the patient's role in decision making. And then we brought 22 women together in focus groups to observe those clips. We didn't tell them how we coded them as effective and ineffective, right? We asked them to watch these, tell us what they thought was done well and not done well, ask them to talk about their own experiences, and then really give us some advice for providers on, like, what is it that you would want in this type of situation? What would be more comforting to you? What would help you in this process? So with our women, the average age was about 36.5 years. Most identified as white and were highly educated. Most were married. And it had been a little less than 5 years since the most recent miscarriage. 13 of our 22 women had experienced multiple losses, up to 4. Okay? So what I want to present to you is these themes that emerged from our data when we analyzed the transcripts of the focus groups of what women really think should happen in that interaction, and then a couple of things that they think providers should definitely avoid doing. So the first thing and the overarching theme that we see through all of this is that providers need to demonstrate empathy in this situation. And I really like this quote where the woman says, don't act like robots. You know what I mean? Act like a human. Act as if it was, say, your wife that happened to, or your daughter, or your granddaughter that it happened to. Think of if you had to talk to them in that sort of way, you know, like in their shoes. And I think that makes a huge difference, you know, that some doctors are great, super smart, but they have the worst bedside manner, you know. I think they just need to be human, right? And I think that speaks to a lot of us. We just want someone to empathize with us. We need that comfort when we're going through a traumatic experience. The second thing is really creating space for the patient to have this opportunity to process this information. So we know from previous research that when a patient receives any type of bad news, if they receive a poor prognosis, a bad diagnosis, we typically don't hear anything past that, right? It's very difficult. So there's a lot of research that looks at this with like a cancer diagnosis. When someone is diagnosed with cancer, they hear cancer and then they don't really hear anything after that, right? And so they need that time and that space to process the information. And so this woman said, she just kept going, and I'm like, oh, she's just rambling. And I felt like, you know, the patient was kind of trying to process it, and she just kept talking. And I'm like, she doesn't hear anything that you're saying. Just stop talking and let her absorb it. So a lot of times we fear that silence, but that's what we need to be able to process that information. Another suggestion that the women had is making sure that we do check for understanding. So really using the techniques to assess understanding, not just, do you understand what I just told you? So one woman said, instead of just saying, do you understand what I'm informing you of, ask, can you tell me what I just told you? Instead of just constantly every sentence like, okay, all right. And they're just kind of expecting those head nods, and that's their way of assessing understanding. And it's really important to provide your full attention to the woman who's experiencing the miscarriage. So not multitasking, not looking at the chart, not doing other things, but really focusing on what the patient needs. And what a lot of women commented on is it seemed like the providers had this checklist in their mind that they were just trying to check off the things that they had to do instead of really focusing on, wait a minute, I can stop, take some time, and really focus on this patient. And she said she was just kind of more actively present. So this is an example of something that was done well. She just kept offering these opportunities for the mom to express what she was thinking or feeling, but she was still very connected. So I think sometimes when providers try to leave room for the patient to talk, sometimes they can seem a little disconnected, and she was definitely like actively present there. So really encouraging the mom there. And the last thing that the women talked about that providers should do is, although there's some general things, right, like providing empathy is pretty universal, we also have to recognize the uniqueness of the situation and that every woman is different and will want, you know, different things, which can be very difficult for a provider. We understand that. But a lot of times the provider would say things like, oh, this happens all the time. This is a very common experience, you know, 25% end in miscarriage, which is true, but that's not a very comforting statement. And although they thought they were being comforting by saying, like, you're not alone, in fact, it was also often dismissing that experience of the woman. And so this is what they're referring to when they say that it's common discourse, to me, is said as a way to get over this difficult piece of having to communicate this awful news and get on with to the next thing. Knowing that this is this person's first time, I don't care if it's their fourth time, you know, they still might not want to hear it's common. So recognizing this is unique for every woman, and even women who've had multiple miscarriages, each miscarriage is unique for that woman. So these are some things that they should do, but what about things they should not do? So there's two primary things that physicians should not be doing when they're communicating with a patient that's experiencing a pregnancy loss. One of the common things that we heard over and over again is to avoid medical jargon or emotionally charged language. So if you're not familiar, the medical term for a miscarriage is a spontaneous abortion. And we know that abortion has other connotations, and so sometimes that can evoke an emotional reaction in some people. And then this woman is talking about that word specifically. Like, she used the word abortion, which for some people is very emotional, and it contradicts. It sounds as if you're contradicting what she just said about you did nothing wrong, because abortion sounds like a choice. It was just heartbreaking because I was like, well, there's no part of me that chose any of this. So seeing that clip recalled something that she had experienced as well, and recognizing like this was not a choice that I made. And it's not even just the word abortion. When they would talk about some of the management options, they would talk about things about like scraping the uterus, or they would talk about sucking, and they would use this hand motion a lot. And that was very troubling for a lot of the women. And then the other thing that you should avoid doing is rushing the conversation. Right? So giving the woman time not only to process, but to ask the questions, to not feel like she's just a number that has to be hurried out. And so this person says, be as personable as possible and try really hard to not seem like you're in a rush. Making decisions when you see that the doctor is rushed is hard, let alone when it's more than a cold or something like it's not like which medicine to get. It's a life-altering for, like you said, that individual. Like, yes, it happens often, but if it had never happened to me, it had never happened to me, so I needed that extra slowdown time. So again, needing that extra time is important. So some of the implications to this particular study is, one thing, when we talk about the methodological approach, which was really unique because this hadn't really been done before, and two things that we think are unique about this. One thing I did not mention is, these are trained actors. These are actual patients. We don't have access to actual patient interactions. That would be a little difficult to get. But we did not tell the women that these were trained actors. So they thought they were watching interactions of actual patients. So at the end of our focus groups, then we did disclose that this was a trained actor, and we assessed realism. And we found out that all of the participants thought it was very realistic, which speaks to the value of using this type of training, these types of simulations, because they thought that the actor did a really good job. They thought they were watching an actual interaction that was happening. And we also privileged the voice of women. So we have research from doctors and physicians that suggest what they think should happen. We see some research from scholars that suggest these are effective communication strategies. But this is the women's voices that are saying this is what needs to happen in this type of situation. And so we give some very specific communicative behaviors to help providers deliver this bad news in this particular context. So where are we going from here? So we've actually we've partnered with the IU School of Medicine's residency program. And this first study that we've done with Dr. Shanks, who is the residency director, the director of the residency program, we've actually taken the information from the last two studies that I had talked about, and we have developed a training module. It's actually a video training module that we have piloted with a group of residents, and we have our pilot data under review right now to assess whether or not the providers can learn in this type of training environment, and if we can make an impact on them so that way we could give them this little bit of information, because we know they don't have a lot of time, but make a huge impact on women receiving this type of information. We're also working with another graduate student that's going back and assessing some of the actual patient-centered communication practices, so looking specifically at those types of language. And then Dr. Butte and I are doing a broader qualitative analysis of the resident communication, not just focusing on that informed decision-making, but looking more broadly at communication that happens. I do want to leave you with a quote, and this came from one of the women who was talking about the healthcare providers and kind of giving her advice to healthcare providers who are interacting with patients who've experienced miscarriage. But I would argue that this is important for anyone who communicates with a patient or with any woman who's experienced miscarriage. So we started our presentation with a quote where a woman had said, "There's no real way to talk about it." Okay? But we want to argue that there is a way to talk about it, and we should be. And so she says, "I think it's really important for future practitioners to know that you're going to mess up. You're going to say the wrong word, and you're going to touch somebody that doesn't want to be touched. There's just so many details that you're going to have that trying to keep track of, make her feel empowered. Make her feel heard and understood." I feel like those are the two most important things, that I feel like I understand what's happening to me, that I have the tiny bit of control that is available to me, and that you hear me. So anytime that we communicate with someone who's going through some type of traumatic event, like a pregnancy loss, make them feel understood, make them feel heard, know that they can be empowered. So with that, we'd like to go ahead and open it up for questions and answers. Well, actually, could you use the microphone so that way it picks up for the video recording? So. Thanks, everyone. I need to take that.
So in some cases, like when a woman has to go to an abortion like facility, like outside of Indiana, if they had to have like a terminated pregnancy because of medical complications, how can they make abortion facilities more comfortable for women? Because I know in my personal experience it was very, very hard, and the doctor that did it was just very, very cold. And he even said things to me that I like had to tell, you know, people higher up because it was just ridiculous.
Mm-hmm. Well, I'm sorry to hear about your experience. In terms of the facility itself, I mean, we haven't really looked at the environment per se, but in terms of the communication, what we see is, why we're talking with residents, for example, is because we're trying to train the new crew, right? We're trying to train the new providers that are coming in to be sensitive to these types of topics and to recognize, like we said, that every situation is unique. So the experience that you have, you know, like the example they have is as an asymptomatic woman, but what if it's someone who's farther along or someone who has a medical emergency and this is to save someone's life, or whatever the reason, it can be multiple things. Recognizing that uniqueness, and you really have to communicate with women and find out what is it that they want, what is their preference, how can they help that woman, you know, manage the miscarriage, but then beyond that. So I mentioned before, the communication goes a long way with mental health. You mentioned that you had been told some very troubling things, and you know that obviously had a mental effect on you because you felt like you needed to report that further up. And so I think we are really trying to educate another group of physicians to know and how to do that. It's difficult with anything that we do when we're in a habit of doing something or we've done something for a long time, someone who's been in practice for a really long time, to recognize the value in this, but we're slowly trying to make headway in doing that.
Other questions?
There's one in the back here, Erwin. Right here.
This is a question about something you might have analyzed in your data or you might not have, but it made me curious because I'm thinking about you know, the sort of stereotype of the 5-minute doctor visit, and I feel confident that the people who addressed the lowest number of informed decision making, 9 rules for that, spent significantly less time than the people who addressed most or all of those. And I wonder if that, I don't know if you analyzed the difference in time, but you did.
Yes,
okay,
ma'am.
so it could be turned to explicit teaching. I'm just curious to know more about that.
Actually, there isn't a significant difference in time. There's not. So yeah, and which is one of the beauties of marketing this to providers. Like, you can do all these things and not take extra time in doing that. So it's actually a good thing for us.
Yeah, and that's also true of research in other medical contexts outside miscarriage, that, and it's a selling point, right, for healthcare providers, that you can do this well without taking significantly more time.
I have a question that's probably similar and maybe a follow-up, but just what's been the response from the physicians, right? So you're starting with the new crop that is coming out. Why not the older crowd?
A couple of reasons for that. One is we are fortunate to have the largest medical school in the country on our campus. And so we have great access to people who are going through not only medical school, but their residency training literally across the street from us. So in some ways, it's much more convenient to address that population. Practicing physicians gets a little bit more unwieldy. We have not tackled that yet, although as your experience illustrates, there's certainly room to do that.
Mm-hmm. And we have had communication, like when we present before, we've had physicians come up and talk to us afterwards. Usually those are the ones who are receptive to the idea, right? But we haven't been able to kind of make any headway in that area.
Other questions?
Up here in the front again, Erwin.
Hi. Okay, so like if a woman is, you know, like rushed, you know, and like the time to grieve, they don't give you very much time to grieve. Mm-hmm. And I just want to say thanks, and I love what you guys are doing.
Thank you.
Thank you. Thank you for being here today.
Yeah.
Well, thank you all. Let's thank Dr.
Thank you.
Brand and Dr. Butte one more
Thank
time.
you.